a quorum?
Not quite yet, but you can go ahead and start the meeting.
Okay. I'd like to call the meeting today for Incarceration Prevention and Reduction Task Force, the Behavioral Health Committee. Today is October 18th, 2022. We are meeting virtually, but we also have a hybrid meeting space. Jill, do we have anybody in our physical meeting space this morning?
It doesn't look like it.
Okay, so just all of us in Zoom land. Welcome and thank you for attending this morning. We kick off all of our meetings here in the Behavioral Health Committee with the land acknowledgement statement, and I just want to mention briefly, we don't read it out to be rote. We read it out because we mean it, and we really seek connection and reconciliation, input, and working together to address our common problems. So with that, before we begin our meeting today, we acknowledge that we are gathered on the traditional and unceded territory of the Lummi, Nooksack, Samish, and Semiahmoo people, who have cared for and tended this land since time immemorial. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We pay respect to their elders, both past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us together here today. And please join us in uncovering such truths at any and all public events that you may attend. Again, thanks for joining us today. I forgot to introduce myself. My name is Mike Parker. I am co-chair of the Behavioral Health Committee. And again, we welcome you today. We've got a packed agenda, so we're going to jump into it briefly. Jill is our wonderful, amazing legislative staff support person, and she gave me a couple of framing things that I just kind of want to remind us before we introduce our presenters. Joe Valentine from the North Sound Behavioral Health Administration Services Administration, quite a mouthful. We're happy to have him here today. And also we're due to have Representative Alicia Rule join us today. And just to recap, our Behavioral Health Committee has really focused on some of the gaps in our behavioral health workforce system. As we have learned about both Whatcom Community College's new program for SUDP, so substance use disorder professionals, and we've been talking with people in the field, we're starting to learn a little bit more about what some of those gaps are. That led us to inviting both Joe Valentine and Representative Rule here today to see if we could get a little finer pine on what some of the possible solutions might be. As a reminder, what we learned was some of the issues were not enough workforce and enough trained workforce. COVID may be tapping out our workforce. We've definitely got kind of a recruitment training issue. That's not the only thing we've got. We've also got really low Medicaid reimbursement rates. And what this committee has learned by many folks presenting to us is essentially that so many of the people that are unfortunately wind up in our jails and our prisons have behavioral health serious challenges, and many of them are on Medicaid. So we're interested in hearing today the thoughts and opinions and maybe some guidance. Can we develop some platform that the committee might be able to get behind and advocate for some changes in this system? So again, we're really looking for some solutions along a couple of those lines. Jill or Dan, do you have anything to add in before we start introducing our speakers today?
No, I think that's a good way to kind of frame the discussion. Yeah, no, go ahead. You're good.
All right. So with that, since Joe is with us here already, I'd like to go ahead or just briefly, Joe, I'm just going to mention just briefly, and if you wouldn't mind saying a couple words too when you get started for us. Again, we want to thank you for joining us today. And just as a reminder, Joe Valentine, I believe his title is director, but is running the North Sound Behavioral Health Services Administration, and as such has a finger on a pulse and also the funding for a lot of the programs that benefit people that we're hoping to steer out of jail and rather into treatment. Joe, with that, please go ahead and finish off introducing yourself, and welcome. Thank you for being here today.
Thank you, Mike, and thank you, committee, for the opportunity to share some information with you. And I will also, of course, defer to Representative Rule as I make these comments. The Administrative Service Organization administers state general fund and federal block grant funds for a variety of behavioral health services, particularly crisis services and diversion services. We also contract with the 5 managed care organizations who manage the Medicaid dollars for behavioral health treatment. Briefly, I was asked to address 3 issues. One is internships, Medicaid reimbursements, and support for providers to navigate the Medicaid system. I will mostly focus on the first. Fortunately, there are a number of excellent suggestions and solutions that have been advanced. There are 2 statewide committees that have been working on this issue for several years. One is the Behavioral Health Workforce Advisory Committee, hosted by the Workforce Development Council, and the other is the State Children's Behavioral Health Advisory Group. They have both advanced a number of really excellent suggestions. They have looked at every aspect related to workforce recruitment and retention. And I do believe, Jill, that one of those handouts I shared with you, and maybe that could be shown on the screen.
Yes, I apologize. Which handout would you like to see?
It's the behavioral health recommendations.
Okay, give me a moment. There you go. Is that the one you're looking for?
That's excellent. Perfect. Thank you. So I just wanted to share with the committee that you don't have to reinvent the wheel on coming up with ideas. There are some excellent suggestions that have been made. One of them has to do with, and this relates to your interest in apprenticeships, and I'll talk about that in a second. But in order for behavioral health agencies to provide training and supervision, they actually need funding for the staff, the professional staff that are providing that training and supervision. That reimbursement is not currently included in the reimbursements that they get from the managed care organizations. So creating that kind of stipend for the agencies that gives them the capacity to train and supervise both students and graduates, I think will be a key. I think increasing the ability of mental health professionals to provide that supervision and training, increasing the training that's available, competency-based training for apprenticeship and students. So there's a number of suggestions here that I think are worth the committee looking at. I think you are blessed with having 2 institutions that I'm aware of in the county, the Whatcom Community College and Western Washington University Human Services Program. Those would be excellent partners to kind of look at some of these suggestions and say how at the county level can you work with those institutions to actually implement some of these recommendations. And then more specifically, you had an interest in apprenticeship programs. So Jill, I'm going to have you bring up the second handout. So just this month, the state actually is rolling out a behavioral health apprenticeship program. And one of those apprenticeships is a substance use disorder professional apprenticeship program. So this program will provide structure, training, and supervision for persons that want to become an apprentice. So again, this is really an excellent opportunity. And again, talking with the college and talking with Western Washington University about how at the county level, can you kind of support efforts to encourage, for example, high school students to go into these programs. So, so I wanted to bring those things to your attention because I think they kind of give you a starting point on how you can pursue some of the strategies that you've been talking about. Let me stop there and see if there's any questions on that one. And Representative Rule, I know you've probably had some of these presentations at the legislature. I didn't know if you wanted to kind of provide any additional comments on that.
Well, thanks for the opportunity, Joe. I think you're doing a great job. I wasn't sure what you were going to want from me today, but you have presented exactly what I had in mind as well. So happy to jump in whenever you're ready, but this is it. This is the meat of it right here.
And I might mention there is a second state group. I think I mentioned this before. It's the Children and Youth Behavioral Health Work Group. They're actually meeting this afternoon. They have similar recommendations, but they put dollars attached to them. And so those funding recommendations are going to be coming to the legislature in this session. So again, there's an opportunity for local committees to advocate for support. I know one of them is relieving the educational debt burden, both tuition reimbursement, a loan repayment program. I think those are excellent suggestions because, you know, clearly a major barrier to folks getting a college education is the cost. And I think that particular proposal could provide a pretty powerful incentive for folks to go into behavioral health. So again, all of those recommendations will be coming to legislature, and working with your local representatives like Representative Rule could be a good opportunity for advocacy on that piece of it.
So committee members, Joe's pausing here for a couple of questions. I'll do my best, Jill, if you would too, if you see a hand raised.
Okay.
But as being a coach, I'm going to take liberty. I had a question as I was listening to you. I saw you mentioned in there, I think it was the behavioral health recommendations phase 2. I think it was that first document mentioned that support for stipends for the clinical supervision and management of folks is important. And I wonder if in that basket of recommendations regarding supporting people through their training periods, if this might fit. I'll bring you an example. So Whatcom Community College, which we heard about, which is also great. They're starting a Bachelor of Social Work program, which is great. I'm an MSW, so near and dear to my heart. I want more of them in the field and in the community. I think they make great practitioners. An interesting niche, though, you know, for those folks that might eventually work with us at the Opportunity Council, getting practicum credit during their college education, there isn't guaranteed funding, which was news to us, for those individuals to get paid. In some situations, those individuals don't fully have the credentials for a position, so they would be in kind of a training type role, right? Well, as you're mentioning tuition support, I think the other thing is kind of work study support. Joe or Alicia, I'm wondering if you might comment on that, and do you see that in the same kind of niche or the same importance, or where would you place that? And Joe, if you said it and I missed it, my apologies.
I believe that's probably included in the apprenticeship program, I think, but I do believe that there's some of the recommendations do talk about providing, there's a lot of discussion right now at the state level about providing as much funding for folks with a bachelor's degree or in a training position as funding for master's level folks. So that is in that set of recommendations. And I think that's, you know, the piece that you kind of need to close the circle in terms of really supporting that. But the other piece is right now for a behavioral health agency, in order to provide the appropriate training and supervision so they can get their license, you're basically using a master's level practitioner. And so you're taking them offline. They're not generating any revenue when they're doing that. And that's part of these recommendations, is to provide a separate stipend to pay for the time that master level clinician is providing training and supervision.
Essentially, they're not doing reimbursable work for Medicaid or Medicare during that time. And
Exactly.
the agency might be a little cash strapped to help out. Okay, I've got hands from both Courtney and then Dan.
I was just going to say thank you for bringing up the practicum piece, Mike, because I'm also an MSW, and I don't think we realize how much our systems rely on social workers, and that we still do not fund them the way we fund other tracks or pathways like we would with medical students or speech pathologists, or there's so much more funding that is still needed, even at the master's level, for folks who are entering the field. Yeah, I think you and Alicia probably know better than I do, but it's still pretty rough, even at the master's level.
Still paying off my student loan, so I hear that. Dan, I think you're up next.
Yeah, I think it's along the same lines as Courtney. I think maybe a question for Rep Rule is the housing costs here in Whatcom County are they're just out of touch with reality when it comes to folks trying to enter the workforce, and then, you know, being like a first or second year in the workforce. So I guess it's like two-part question is like, how do we make internships realistic financially? And then how do we, when the person is then in the workforce, how do we make it so that they can afford to live here and not spend over 30% of their income on housing?
Yeah, thanks. I'd love to jump in and just to catch up, I guess, and back up a little bit. These behavioral health task force at the state level, or both of them, the one that's specific to children and the healthcare one I've participated in. And they really have robust conversation that's very similar to, I think, some of the things you're tackling here at a local level. So I feel encouraged by that because I think that much of that work that's been in place for years, as we move forward, it fits with your priorities. Going back just to catch up a bit, and so yes, Dan, you're right. This is the problem. But it's not just a problem at the internship level. Frankly, it's a problem at every step of the way. So there really isn't a place where you can look on, the career path of a social worker and say, well, that place fits and it's in accordance with what you might expect for somebody of that level, because truly at every single level, it's well behind what other things are. So, for example, somebody who's a senior social worker, they're still making, at this point, the way that this is playing out, they're making essentially the same amount that somebody who comes right out of graduate school can be making. So the market as it is, you've got the most challenging place to get an appointment for outpatient therapy is in the private realm. So we've got, we know this, right? Especially for kids. We know that there's long waiting lists, and we know that it's very difficult to access appointments for clients who need them. That isn't a surprise to those of us who've been trying to advocate for something better. But what surprised me the most is that when we put in this helpline at Children's Hospital with state money to help people navigate that system, what we learned is the wait times are now even longer for private pay, like your commercial insurances, than they are for Medicaid, which we already know is in a disastrous state. So neither one of these systems is working well. As a provider, if you want to make the most amount of money, you're not dealing with either one of those things. And so we see people coming out of grad school, getting their supervision hours, like is being talked about in this context, paying for them, and then going straight into private practice. This system wasn't really designed for that to be the case. Insurance will not pay for that, but there's such a need that they can build a whole private practice straight out of grad school, pay for 1 hour of supervision contracted, and do better than working in a Medicaid-based system or with private insurance, having less experience than many people who are working in those systems. So, it has sort of this embedded problem at every level that we're just not getting pay equity. There has been some talk that I'm very interested in, very, very interested in, around parity. So all of the discussion to get pay up that's happening right now has been kind of a long-term battle of how much, most of what I hear in the rooms of those meetings, how much can we ask the legislature for and how much can we get? So this last session, we went in and I certainly, that was on my top of my priority list. So I went in and advocated on behalf of this group and said, this is what we need for behavioral health. We need to get these Medicaid rates increased, and we got an increase, but it wasn't even enough to keep up with inflation. So that whole time I was saying, I think we should ask for more. But, when you look at it, you're like, well, what's 8%? That's not much. And governor's budget comes out with X, and we're trying to kind of negotiate it. But, 8% seemed like it was at that time, like people were like, we're not going to ask for 8%. That's insane. That's like so much money. But when you put that up next to inflation, that's like barely keeping up. And we did not get 8%. So we're going to go back and we'll ask for more next time. That is for the Medicaid reimbursement rate. But, that doesn't do a thing to private pay. I mean, not private pay, to commercial insurances. So I think we keep doing all of those things, right? Like we don't stop doing any of those things. But what I'm really interested in, and it's the bold ask, is parity. Because parity would say, if you can go in for a 15-minute appointment with, and this is rough speak, right? But generally speaking, if you go into your medical provider for 15 minutes, they're going to get paid X. And, a social worker or a mental health professional might get a fourth of that for that same time. So there's no parity happening, but there's a national conversation that's bringing up the question. And I kind of feel like, why couldn't we do that in Washington state? What's holding us back? We know that we have a collective political will that we want to move into another direction. So that's the conversation I'm particularly interested in. what if, could we, we'll certainly, I've got some meetings set up with the insurance commissioner, but what would happen if? I've also been sitting on a mental health caucus with just a handful of leaders nationally. So we are kind of looking like, what can we do across federally, accessing federal dollars, and then moving the needle in a really more bold way in mental health. So that's a lot. It doesn't necessarily say, what do we do for housing? But I think that's one of the levers that we should be looking at to push things forward, not just to say, we're going to do a one-time, housing scholarship for those who, but to say, maybe what we really need to do is professionalize this group so that they can make a living wage, because we're losing people along the way. They are experiencing secondary trauma, the pressure is high, and then we end up losing these folks after they've even gotten all of the education to a job like Starbucks. I'm not exaggerating. There is a social worker right now, former social worker trained, who's working in the drive-through that I bump into once in a while, and I've had conversations around this very thing. But the stress is better at Starbucks, also a hard job, and they were getting paid pretty equally, and so that's what they decided to do. I don't think that is anomaly. We hear that throughout the entire state on these behavioral health work groups that we're sitting and working with, that this is something that happens pretty regularly. So we have to work on multiple things at the same time. At the front end, there's a lot of work that I think we'll see in the next 1 or 2 years, because the matching funds that are coming from the Balmer Group. So I think we'll see a lot of things happening and shifting on that front end of how to recruit. But I will also say we need to work very hard at making sure we retain. So it's both things. Yes, we want to recruit. I think our workforce pipelines can and should improve in some of the ways that you've been hearing about. It's super exciting that BSW program at the community college is the only one in the whole country. So can we go and make a request for budgeting for those internships? Absolutely. And I would be happy to do that, because we in Whatcom County are often the leaders on things like this. We've been leading in a lot of pilot things around behavioral health in this community. And as you know, pairing it up with law enforcement and doing things differently. So it's a really good opportunity for us to say, we're doing something that maybe the nation can look at. Can we get funded for these internships? But I also want to make sure we're talking about the full spectrum.
Thank you so much for those comments. We've got a couple of folks queued up. I just want to ask the presenters, one of the things that this behavioral health subcommittee has really pushed for is using a racial equity toolkit, using a lens. And I would ask you both, I'm going to call on some people, but just think about, do you have anything that might further either the recruitment, right? Because we know research tells us anyways that when folks are treated by folks that look and talk like them, we can get some really great outcomes. And one of the things is not just getting a behavioral health workforce. Can we get a workforce that looks and sounds and talks and has the same language, right, as much as possible? And so obviously we want a diverse workforce, and that's an important thing. The other thing that I would just ask both yourself, Rep. Rule, and Mr. Valentine to think about too is how, and you were touching on a little bit, we want behavioral health trained folks. We love social workers. We also want people who are really interested in working with folks in the criminal legal system. So if you have any particular thoughts, we haven't really gotten very specific about that, whether they might be placed in a police, with the police force, or just kind of like with Laura Christensen has, working with folks who are frequently being contacted by our criminal legal system. So with those two things to reflect on, I'm going to call, we got 3 people in a row. We've got Courtney, Stephen, and then Dan. So Courtney, you're up.
Okay, so I just want to circle back to the mention of parity. Alicia, I am so happy you are in the position you're in, because this is why we need social workers at the legislative level. And what you're talking about is a holistic approach, and it will naturally develop the diversity that Mike is speaking about, because we are impoverishing our social workers. And who are already working with clients that are already navigating a variety of systems that we can't even navigate very well as folks working within them. And so I really want us to circle back to that before we lose. I mean, what you're talking about is the root of all of these issues that we continue to revisit. And I really want to highlight everything that you just said. So thank you.
Thank you. Yeah, that's kind of my thought too. That was my original, when I heard the question proposed in front of us, it's like, well, it's that. It has now been, it's been a long time, like 20 years ago or something. I worked in the county of San Diego and I was tasked with recruiting. There's a program down there called the Title IV-E program. And so that was my job, is to figure out what we were going to do in the child welfare system to increase diversity. And we did that through multiple things. Many of you probably, I don't know if you all are familiar with this, but one of the things it did was, in my role, was to pair up the university's students with those who were working in the child welfare system in San Diego County. That was, I think, the 5th largest county or entity that was doing this work in the country. So it was a large scale effort to recruit candidates of color to get into a workforce pipeline for child welfare. That's been, like I said, almost 20 years ago. We still have the problem today, but it's money. It's really money is a huge part of what we need to do, is to make it possible for people to be able to pay for the education they need in one way or another to be able to get it. We expect, and it makes sense, that we need to have fully trained people. Just wanting to do the right thing is very important in this work, but it's not enough. It's professionalized work that requires a good solid training to not get yourself in trouble, right? Like, I want to do really well and I really care about people, but I don't have the training, so I might get myself into a real pickle. So we need that professionalization, and so I'm happy about that. But we need to make sure that folks have equitable access to be able to enter that workforce pipeline at whatever point makes sense for them, starting with these BSW apprenticeships and moving through with all those steps along the way. In addition, I would just say that just this last session, I advocated for some, again, funding for the University of Washington to do some work around cultural competency in clinical care. So we should have that work presented really in the next probably month or so. And we'll have more to work with to look at what we can do to take those outcomes and embed them in at least our state in ways that can be helpful toward increasing competency, cultural competency in clinical work.
And Mike, one comment you made about training workers to work within the criminal justice system. I know Whatcom County is doing some very innovative things. One of the things that we've learned in our region in funding these co-responder programs, pairing up social workers with law enforcement, is that social work training doesn't by itself actually prepare a social worker to work with law enforcement. And we discovered the hard way in Skagit County, when the fit wasn't very good, that you have to train both the social worker on understanding the role of law enforcement and train law enforcement on understanding the role of behavioral health. So I think there's a lot of opportunities for cross-training there.
Thank you for that comment. Yeah, no, that's a great idea. We actually looked at, I believe they called it the Impact Program, if I'm not mistaken, in Skagit, that we looked at that model.
Right.
Next up is Stephen, followed by Dan, and then I also see Mike Hilly. So Stephen, you're up.
Thanks, Mike. I'm the co-chair of the task force, but I'm going to be wearing my advocate's hat here. Joe, good to see you again after a couple of years. Representative Rule, thank you for taking the time in the end stage of the campaign to be with us. I appreciate that. I really value the front end, the front door, the entry point that Joe, you reported on primarily for entry into this workforce. But really, I think Representative Rule, you hit the point that we've run into dozens and dozens and dozens of times. And that's A, the retention point in the workforce, and B, the fact that our interest is folks working in maybe the most demanding, draining, challenging part of the continuum in the provider field in the criminal legal system. I can't tell you how many times we've heard that the reimbursement rate for clinicians is simply inadequate to retain people or to incentivize them to do this work. And so here locally, we're in the midst right now of trying to plan a proposal for a new desperately needed jail.
Mhm.
The size of that jail will necessarily depend on the ability to build nest diversion and treatment programs around that in the community so that people who don't need to be in a jail but need to be in treatment can have a more productive option. So when I hear 2 years, 3 years, push back on 8% raises, 10-year plans, that just doesn't work. And we're not alone. This is every county in Washington State. And so I guess I want to express some frustration and some impatience, but also you two are insiders. Where are the fulcrum points that we can put more pressure on the system? I don't understand, because the cost-effective arguments are so strong to keep people out of jail, to get them treated, to restore some productivity and constructive participation in the communities at a lower cost. I don't understand why we have these problems. And I think you're here by invitation because we've come to the conclusion that we have to be more assertive about what community needs are in this area. And I think we're looking for some guidance for how to be that, how not to accept 10-year proposals that may or may not work in this end of the provider spectrum. Any suggestions from either of you on that more urgent note?
Well, I'd like to make one comment, and I'll defer to Representative Rule. The legislature did appropriate a 7% wage increase. And as Representative Rule said, that's not enough, but it's a huge start. Unfortunately, that's not what providers are probably going to see in their rates, because the state actuary who recommends what the Medicaid rates should be is proposing an overall rate decrease for the base underlying rate. So by the time the money works its way through managed care organizations to providers, it may be a wash. And so I think, part of the advocacy needs to be, how does the state actually go about determining what behavioral health Medicaid rates should be? What do they look at? And unfortunately, they looked at a lower utilization last year. Hello, COVID. People couldn't see their workers as much. And a higher percentage of people were in Medicaid who traditionally did not have behavioral health needs because they were displaced. And so that's lowering the mathematical rates. Now, of course, a lot of those folks are returning to the workforce. So I think you have to kind of look at the overall process. I think it's going to require a lot of heavy lifting over a period of time, not just a one-shot 7%. I think it's going to require quite a bit of support over a period of years to get to that level.
Yeah, I would agree. What comes to mind for me, a couple of things is, as I mentioned, I don't think that is the gold nugget for mental health or behavioral health. I think that there's a misunderstanding as a whole. I think there are some people who understand, but there's a misunderstanding as a whole in the legislature about what we need to do and the level of commitment that we need. It's much bigger than we're doing right now. And I don't necessarily think, by the way, just to be clear, that this is a Washington problem. This is a national problem. And that's actually probably the biggest thing. We need to put a ton of pressure on our federal delegates so that they begin to put this to the, and of course, there's a lot going on in DC and none of it at least from my opinion, seems to be producing excellent results. So that's a frustration I have as a whole, but I never miss an opportunity when I meet with them regularly with our federal delegates to push that to the top of the agenda, because there's always a lot to talk about, but without support at a federal level, it's really difficult for any of us at a state level, whether it's Washington or my colleagues on the Mental Health Caucus, to hold that level of weight in the behavioral health space. It's just very expensive. So in order to do that, we've got to be able to secure that federal funding at a much higher, much more aggressive rate than we've seen. I see a lot of conversation in that space that looks promising. It looks like, there finally has been a shift in how we think about things enough to have the conversation. And that's actually a pretty big deal, and it's fairly new. But that's where I think one of the levers is to put a ton of pressure on our federal delegates to get that money down to states so that we can do some of the things that we want to do. I also think that it's important, as I mentioned, to put some pressure and do some work with the insurance space, the commercial insurance space. That's hard. I don't have to tell you that, but I think we need to continue working on that space. And then the last thing I will say, and again, this probably seems bold in these times, but I'm going to say it anyway. If you could possibly get the political will of all that is interested in mental health, behavioral health, and law enforcement, and to recognize we're all kind of working with the same population to some extent, and we're running into the same challenges. We all are desperately in need for staffing. We're dealing with burnout and those providers and law enforcement feeling very unappreciated and unsupported. If we can somehow get that political will to work on the same page, now you have political power, right? So let's see what we can do to push some needles with that. Let's see what we can do when we say, hey, we're not working opposed to each other. We need to work together, because oftentimes it might even look like working in the same room together, but our systems are colliding every day. So how could we use that momentum, the political momentum that we're feeling now, to see systems changes and funding that can work for the collective space there?
Mike, if I could just interject a follow-up. Thank you both for those comments. Let me just say that I think, my experience in advocating in any of those spaces, Representative Rule, is voices of experience help. And so if in any of those conversations, Joe, with any of your other regional partners, Representative Rule, whether you're talking to federal people, state people, private insurers, whatever, please call on us. You have boots on the ground here with experience in these problems and how they impact communities over decades. So I think we are activated as a group, and if you need voices alongside you to talk about what the real experience is like in communities, please give us a call, and we'll have partners there alongside you.
Stephen, I was going to follow up. I thought your point was really good, asking about the fulcrums and what that point was. And Joe, you mentioned kind of the actuarial mathematics that happens that can end up what looked kind of like a win, like 7% boost. And Rep. Rule, you mentioned that wasn't even enough. To hear that that could be a wash based on some math that we do behind the scenes that we don't see. What might be a lever or fulcrum there? Are we talking about our Medicaid director, Dr. Fontos? Where is a spot that we might be able to go with that type of concern? Because from what I'm hearing about the calculation you're mentioning, it's not mentioning the reality that we see on the ground, both for the people that are doing the work, nor is it fitting the reality for those that are on the streets that we end up arresting because we can't treat. So could you, Joe, if you would, could you provide a little bit more? Well, I don't know.
Sure.
Where might we get more targeted about our fulcrum here?
Right, and I'm not the expert. I think Representative Rule's focus on parity is probably the best long-term solution. It is the way that our state uses Medicaid dollars to fund behavioral health that I think has a structural problem with it. It's all based on fee for service. It's not based on capacity. And not every state approaches it the way we do. We approach it within a very narrow way. And so as your capacity suffers, like it did during COVID, then the money that's calculated for your Medicaid reimbursement the next year is lower because your capacity, it's kind of a death spiral is what we call it. So I think really working with Representative Rule and others on looking at the fundamental way that we use Medicaid dollars in this state to fund behavioral health, I really think that's where there needs to be some attention.
Oh, key too, right? Because we do get some match from that. Thank you both for your answers in that. Councilmember Hamel, you're up next, followed by Arlene and then Courtney again. So Councilmember Hamel, please.
Yeah, I don't know that I have much to add to this conversation. I'm beyond frustrated. I agree with everything that Courtney said and Rep. Rule, Joe, Stephen. We're all saying the same thing. We all agree that there's not enough, I guess, funding for what I regard as one of the more serious problems that our communities face across the state and across the country. So I want to, and I don't know that it's fixable in our lifetimes. I just don't. I have a lot of confidence in that. So what I've come to regard politics as sort of like a science of incrementalism, and you just kind of take what you get. And if you get 50% of what you want, victory. 100% never going to happen. So I'll focus in on something that I think that we might have a shot at, and that is I just toured the jail last week, and I spent a couple hours in Whatcom County Jail on a tour with Caleb Erickson, Lieutenant Erickson, Rebecca Mertzig, who's our new police chief, and Councilmember Huffman. And one thing that I learned was that we have a number of people that are languishing in Whatcom County Jail because they are awaiting competency restoration that's performed by Western State Hospital. And if I were in jail and today and I needed a competency restoration, that appointment would happen in May of next year. So I would sit there in Whatcom County Jail pre-trial, haven't been convicted of anything, but was awaiting competency so I could stand trial. I'd have to wait there until May of next year. And then there's a period of time in Western State where it takes a while and then get shipped back and then get a court date. So it could be in fall of next year so almost a year before a person could stand trial. That's not acceptable. That person is probably traumatized, is languishing, is not, they're not Medicaid eligible while they're in jail. There's all kinds of issues with that. And it's just not a fair system. So what I'm asking for is a way for local counties to have some kind of, whether it's in custody or outpatient, or doesn't matter to me what form it is, but it has some kind of competency restoration ability. So we're not waiting on a third party like Western State, who is overburdened with all of the counties are shipping their people there, and to Eastern as well. So how do we then provide services for our most vulnerable people who have committed a crime? Some people, according to Lieutenant Erickson, don't even understand why they're in jail.
Most of them don't.
Right. And so how do we, so I don't believe that we're ever going to get to the big picture of parity. I hope we do, but I just don't believe that. I think our system is so backwards that it's not going to happen. But if we can take chunks and in this incrementalism, if we can do that, then we can make some dent in this problem that we have. And I think that there might be a way to do that. And I don't know. I'm just, Courtney, you probably see this a lot more.
I'd like to jump in. Yeah, I work
go
at
ahead.
the intersection of all these things. And so I'm kind of vibrating in my chair as we speak, because I feel the passion, Dan, and I can't tell you how it feels good to hear some other folks frustrated, because I am frustrated. And you're right. We are in a pickle. We have a lot of folks that are sitting in jail, decompensating, not getting access to medications, not able to be transferred to the hospitals. And the public defender's office is very limited with what they can do, because we are also beholden to the adversarial court system. And so, yeah, we have to acknowledge that. And at the root of that, I think we have to circle back to parity. I mean, we have to be bold. We have to be. How many generations have we been talking about this same thing? I mean, I can tell you, as someone who's returned to Bellingham, I was here as an undergrad student. I was here before that. I was in the field as a bachelor's level human services student. I'm back here in the field as an MSW. The problems have gotten worse. And I don't mean to be grim, but it's so disheartening to see the community that I love like saying the same things over and over again. We have to be bold. Alicia's right, and we have to acknowledge that what we've been doing has not worked.
Really quick, thank you for that jump in, Courtney. Arlene, we're going to get to your question. And I just wanted to, as co-chair here, just kind of dive into this super briefly. So, you know, the sheriff's office and unfortunately under Sheriff Doug Chadwick couldn't join us today, or else I'd have him jump in on this. They put forth kind of a series of recommendations in a letter that was made public. And I believe that one of those was looking at, could we have some local resource to do competency evaluation in Whatcom County, not beholden and dependent on a new hospital to be figured out for the Western capacity issues to be done, but more of a localized solution. And I'm wondering if there's anybody that might be able to speak to that particular thing. Would this kind of, Courtney, Dan, Rep. Rule, and Joe, would this in some way be a lever that we might be able to push locally until such, you know, larger systems can be fixed? And Perry, I don't know if that's why you're raising your hand. If it is, then please jump in, because I think that, and Arlene, I'd love to hear you too about that particular idea, because this has come up with what Councilmember Hamel brought up. This particular facet issue of why our jail is full of folks waiting for competency. Is this our solution? Arlene first, maybe. Arlene, if you're going to talk about that, then Perry, please.
Yes. What I wanted to talk about was sort of the opposite attitude of what I'm hearing. And that's that I really believe that this can happen and will happen to get what we need. I want to suggest that we think about it in terms of what has happened for law enforcement regarding compensation. The attitude, the political will, the acceptance of all our communities and politicians that law enforcement should receive extremely good compensation, and no one questions it. In our county budget, twice as much money goes to public safety as to social services. So when you're in a position of persuading people to come on board with what it is we really need, then try to remember that social services, mental health services are surely equal to the importance, the social safety importance as law enforcement. And you may be able to do some persuading with that. As far as competency is concerned, I do have doubts about our ability to provide the psychiatric services and, if necessary, psychiatric stays on a local level. I know that Governor Inslee is planning for eventually 4 hospitals, regional hospitals, but that's 10 years away. So I don't think it's realistic to do competency hearings here unless you have the services of several psychiatrists as well as highly skilled people to do this kind of work. But on the other hand, as far as power levers, this conversation today is absolutely essential. It's incredibly exciting to hear you talking together, because all the knowledge that we have in the field of that we're working in is in this room, this conversation. And so you're talking about the fulcrums, the pressure points, the politics, all of that is part of trying to make these things happen. And that means everybody in this group has now the knowledge to use when they're in situations of being able to persuade people in power. And you need that knowledge, you need that understanding. And I agree with Courtney totally. Be bold. Go after what you really want. And we can do this. We can get what we need for this. Look at what's already happened. We've accomplished a lot. It's pretty stunning.
Thank you, Arlene. Perry.
Good morning, folks. Perry Mowry, Response Systems Division Supervisor with the Health Department. Yeah, a couple of things about the restoration component. I think that some folks are aware that County Councilman Buchanan has convened a competency restoration work group, taking a look at some of the things that are going on out there, and and what is possible and available. I can just provide a couple of brief bullet points in that regard. I was surprised to learn that in regards to competency evaluations, probably by virtue of COVID, that virtual evaluations are occurring, and actually within 1 week of the court order, the evaluation can be completed. So my understanding at this point is the evaluations is less of an issue because of the ability to do that virtually. And so, that's obviously a positive. As it's been noted before, the competency restoration, settings in terms of Western, Dan Hamill, obviously made reference to the period of time in waiting. And sometimes, again, another piece of information that came up as the individual returns and awaits trial, sometimes medication is oftentimes a component of that restoration, and the individual may actually choose to disengage from medication at that point. Jail does not have the opportunity to compel the individual to take medication, and decompensation can happen again. So, another added piece. But one of the things that we have been looking at and are going to investigate further is the possibility of sort of more local work relative to individuals that meet a criteria for outpatient competency restoration services, and or also prosecutorial diversion programs that are being implemented in several counties. Well, 3 counties, I won't say several, 3 counties within the state at this point in time, one of them being in King County. So there's some components of that. That's sort of where we're at in looking at that with that particular work group. That being said, this won't necessarily address those individuals that are being charged with more violent crimes. So it wouldn't necessarily reduce, that particular number. So I wanted to offer that information, looking forward to that. One of the things that I'm planning on doing is actually going and visiting King County. Sort of made some contacts there relative to their prosecutorial diversion program and how that's working for them and what they're finding the challenges are, and and so forth, which brings us back, of course, to the workforce challenges that we talked about. But nonetheless, there are some smart people out there that are doing some work, and gives us an opportunity to to take a look at what possible resources we have. If I can, so that I don't have to jump in again, and it's sort of, I don't want to take us away from this great conversation, but from the perspective when we were talking about resources and supporting workforce and so forth, I don't know if this has been brought up, and Joe, or a Representative Roy can certainly make reference to this as a SUDP at this point in time. One of the things that I think could be a possibility in retaining the workforce is the piece of, there's a $300 cost for certification annually for substance use disorder professionals, in addition to paying for continuing education requirements, which are absolutely essential in my opinion. But again, that's a cost. It's a very immediate cost for a professional that could be considered in regards to some kind of incentive in terms of retaining professionals that are currently in the field. The other thing that I will say, and it just sort of, it's an internal thing that oftentimes worries me as an old clinical supervisor, the risk of, and Representative Rule made reference to this, but the risk of individuals that have less experience, less training, and et cetera, working with individuals, as we all well know, that are struggling with very significant dependency issues relative to opioids, relative to methamphetamine. The bar is really, in my opinion, has been raised as far as the level of expertise that a substance use disorder professional needs in order to be successful in providing the treatment. So I mentioned those 2 things just from my heart. So thank you for the time.
Well,
Thanks for
Mike,
that,
I'll just
Chair.
make two quick comments. I have to jump off for another meeting, so I apologize. But on the paying for licensing and certification, the legislature actually did appropriate state general fund dollars for behavioral health enhancement. And we have distributed those dollars to the agencies we contract with. They can use some of those dollars for that. There are also Medicaid dollars for behavioral health enhancement, but I don't know if the managed care organizations are allowing those to be used for what you're talking about. The only other thing I want to say before I jump off is, as a longtime social worker, I think I have come to the conclusion there's never going to be enough psychiatric hospital beds. There's never going to be enough competency restoration. Ultimately, at the end of the day, we really have to make sure we're focusing on children and youth behavioral health needs. I really think that's the only way we're really ever going to kind of dig ourselves out of this. So again, thank you so much, committee. You guys are doing great work, and I'm always happy to join you again in the future for other conversations.
Thank you so much for your presentation today and sharing your time and wisdom. We appreciate it.
You bet.
Courtney, I see your hand up, and then we will probably start shifting soon so that we've got enough time for Melora to tell us about Grace, a program that's working in our community. Courtney, go ahead.
This is just a kind of a rhetorical question, I guess, but on the topic of restoration, because before I came back here, I was actually in Washington's first OCRP, and I can tell you having outpatient didn't make the flow much easier. And we continue to, I don't know if I want to imagine a future where we still have this many calls for restoration. And I'm wondering how are we as a community and those that have this ability to define what is a crime, how are we revisiting that? And can we explore other ways of responding that aligns more with the restorative justice model? Do we need to involve people and their families and the victims' families and or alleged victims and alleged victims' families? Do they need to be further institutionalized than they already are? And how can we approach that? And I know that that's another tall order on the list, but I want us to think about that, because the way we talk about restoration, it's kind of already assuming that the person is guilty and that a crime has been committed. And there's a lot left to be said about that.
Really good point. Representative Rule, did you have any comments about that or any of the seeds that I planted earlier about ways that we could balance racial equity as we go about advocating for, maybe it's better reimbursement, maybe we're advocating for a better trained or better recruited workforce? Wondering if you have any thoughts on any of those topics for us.
I do. Most of all, I appreciate this space to have these really good and hard conversations. And you all have done something very incredible here, that you've brought together people who outside of this space might have a hard time seeing past their own particular, box. And you're doing it really well here, and you've been doing it for a long time. So on a very practical level, what I'd like to offer is to say, the way I see it in this space is the time is now. So if you know me as a legislator on a whole, I tend to be pretty cautious. I tend to be very pragmatic, and I do see myself in many ways, for better or for worse, as an incrementalist. In this space, I think the opportunity is in front of us right now, and we can't really afford to drag this on. I think this is the time, and this is the space, and you all have the expertise to lead. So I think that we should go bold, and I think we should have a very clear vision of what we want for Whatcom County in all of these things you're talking about, and for Washington State. Whatcom County is a leader already, communicating that to the state. It's probably hard for you all to see that because you're in the middle of this. What you're doing here is not usual and typical. There's a lot of conversation happening, but what you're doing here really is leadership. So I'd love to take your questions, your concerns, and essentially a wish list, and bring it back and work wherever I can to try to get what you want. So please, early on, one of my mentors said, no asking, no getting. And I say it all the time. And my staff is like, please stop, but it's totally true. If we don't ask, we will not get what we want. So my request to you would be clear, put together a list and get it to me as soon as possible. And then I would love my job to be to go back to Olympia with that list and work on those levers, because I feel pretty familiar with where they are. One of the questions that we don't know the answer to is who will be the new chair of the healthcare committee. That's a big deal, because that person, as you know, holds the keys to what policy gets heard and what does not get heard. They also have a lot of influence around budget. We can access, I believe we have a very good chance of accessing behavioral health dollars for what we want to use it for, because I sit on the capital budget committee, which is all the buildings. There has been money allocated, and there is political will. So now is the time to ask for all of these things. We do have staffing challenges. Those things are statewide issues that we're looking at that don't need to necessarily be specific to Whatcom County, because they're not specific to Whatcom County. We already as a state know that we have staffing challenges in all of these spaces. All the law enforcement needs more staff. All of the mental health places need more staff. Like, there's just no place that we have room to not work on that. So that is what these groups that are existing are already really pretty focused on. That work is ongoing and it's happening. My question for you all, and you can discuss and come back to me, because I do have to get elected first. But if that happens and you can come back to me and say, these are our priorities, we agree that we think these things specifically in Whatcom County would be helpful, then I'll go to work, and we're in a very, very good, solid political position to get what we want. Now would be the time. Don't wait. Don't ask for something small. I'll go to bat in a big way on this area, not in every way. This is a priority. I'm the right person at the right time in the right place. Let's use that to our advantage to get you all what you have been working on for years. And let's not say, well, let's only ask for one thing and not the other thing because we think we have more of an opportunity to get it. No, please give me a complete list. And then as I'm in conversation in all these spaces, I'm pretty good at picking up on, hey, there's an opportunity. I see a window. I'm good at that. I'll do that for you. But I need to know specifically what will be most helpful. I haven't heard anything that shocks me today. It seems all in line with what I understand are the most important things. But I do think that putting that together in a way that kind of prioritize, hey, we would put, our weight in this area and then make a list. It's possible that you could get what you want. And so I don't even want to say no to ourselves before we ask the question to the people who can say yes. Not promising, not over promising, but promising that it's worth asking. So I think we can absolutely work on parity, which is, and we got to look for timing. If the conversation is budding already, let's push it along. There's a conversation budding around parity. Let's push it along and see what we can do. But that doesn't stop us from working on building a building that will eventually be able to help us locally with competency hearings right here, if that's what you want. But it has to be clear that that's what we want to do. I do think that I don't see any political opportunity right now in terms of the climate, that folks are not open to the idea of re-centralizing behavioral health care for the state, in one place. I hear conversations that locally, sometimes people think, well, maybe we should go back to that. I don't think that's a good place to spend our time right now, because I don't think we'll get that. I do think that the move right now is to figure out, knowing that nationally and in our state, regionalized care is the way of the future. We should figure out a way to make that work best for us. That's just my advice, knowing what I know, right? You can agree with that or disagree with that, but that's kind of what's happening. So let's figure out a way to make it work for us. And then we'll continue to work on the things that we're doing in terms of, yes, we still need to get reimbursement rates up. That's not going to change. But that's not the magic bullet. And then we still need to continue work on all of these workforce pieces and the cultural competency piece. All these things can happen, and they've already started. So once they've started, let's let that continue to keep going and push it forward. But what do we want locally? Because I'm ready to do that work.
Thank you so much for that. I think I hear that, and you know, as a co-chair of this, and I invite Stephen too to accept that charge. You know, our incarceration prevention reduction task force has taken this on a couple of times, and realizing that sometimes we need to put our ideas to paper and we need to push them. And I think, we appreciate the compliment. I'll just say on behalf of using a royal we of the expertise that's here. It's certainly not really in myself, but we do have a dedicated group of both law enforcement and people really dedicated to changing the conversation around behavioral health that work together, I think, in a very positive way. So I personally, as long as my co-chair Dan, I'm guessing I'm going to get a nod out of him, that we're going to really put pedal to the metal and try to work on that list and work with yourself and others to try and advance that agenda. Dan, did you want to say anything else as we close out, other than a big hearty thank you to Rep. Rule before we welcome Laura to speak?
No, well, thanks, Rep. Rule, for taking time out today. I guess my list would be pay social workers the same as firefighters or police officers because they do the hard work, and let's figure out a way to do competency restoration at the county level, at least here in Whatcom County. Those are my two big asks today. And again, thanks for coming.
Thank you.
Thank you. My request specifically would be if you all could put something together. I mean, I'm this practical, I really am. By January would be great to have a magic list that says we agree on these things, and then I'll get going. Sorry, Courtney.
We'll do it.
Thank you.
Oh, I was just saying thank you to you and Dan. I appreciate the responses. I'm just happy to hear the conversation that's happening right now. So thank you for coming.
My pleasure. It's such a pleasure to be here with partners. I mean it when I say you all have been doing leadership work for a long time, and you're doing what is somewhat unimaginable in a lot of spaces. You're working together, you're disagreeing and agreeing until you get to better policy. And I think that we should take it and put it to work.
Thank you again. That's outstanding. Well, on that note, thank you again for coming and spending your time with us today, Rep. Rule. We will work on that list. And next up, we have Laura Christensen from our GRACE team here in Whatcom County. Really quickly, as I introduce Laura, I think we all know, and she has graciously agreed to join us again to share some stats. I just wanted to share just a brief anecdote about things at work. A lot of times we focus on things that are broken, and there are an awful lot of things that are broken. This morning, my wife getting on the expressway noticed a person who was pretty confused on the expressway. And after just hearing, you know, local news reports about somebody being struck on our highways, it just with great concern. Well, I got on the phone and thought, you know, this probably isn't an emergency department thing. This probably isn't a 911 thing. Don't know if they're GRACE. I called the hot team. The hot team responded in about 5 minutes or less than, and I got a message. I didn't take the call. If they were going to go check it out, they'd be happy to look. You know, I just want to highlight that we do have some programs that have worked. I think our push, our advocacy, our drive for better, sometimes it pays off. So with that, I'm going to introduce Laura Christensen. She's manager of our GRACE team. Thank you again for being here today. Just a heads up, unfortunately, both of your co-chairs need to leave a bit early. And so thanks again to Chief Tank for closing us out at the end. So if you see me drop off, Chief Tank, I'll give you a heads up and you'll take the reins. So thank you for being with us, Laura.
Yeah, thanks everybody. Thanks for the opportunity to check in with you all, talk about our programs. I'm going to share my screen. So can folks see that okay? And I can't see all of you now.
We can.
Okay, thank you. You see the big screen with just blue and white?
Yep.
Yep, all right. Well, great. I don't have a third screen, so I can't see your faces. So I would just say, please, if you would like to ask a question or have a conversation about anything I'm talking about, please just go ahead and jump in. So thanks, Mike. Laura Christensen, I am the Response Systems Manager for the Health Department. And that is a new division in the Health Department that came about this year in 2022. And we operate multiple diversion programs, many of which you are quite familiar with. So GRACE, LEAD, our mental health court, and then we will be launching the new alternative response team in the city of Bellingham this year, and the co-responder program with the Whatcom County Sheriff's Office this year as well. This response systems division, once we're fully staffed, we will have 19 direct service staff working with individuals in our community with complex needs. And this is just a timeline. You might have seen this before, but it really highlights our existing programs, what's coming, and then of course the way station, which is another project that we're involved in. All of our community-based programs are a mix of long-term supports, addressing immediate needs, and providing short-term services. And I can't even talk about our work without talking about our partnerships and community collaborations. This work, all of this work, similar to what you all were talking about earlier, is a specialized response to our community needs. And the network of response from our 911 dispatch, dispatchers to our fire, our law enforcement partners, our housing, our shelter providers, our outreach teams, the medical clinics, our mental health providers. We do this work together. And I agree with the comment that this is unique and we have a lot to be proud of. The folks that we serve are people who are in and out of crisis, and they have unique needs that the systems often aren't able to address effectively. One thing to note that in all of our work, we are striving to provide a continuum of care that focuses on prevention, intervention, treatment, and aftercare. And again, our community partners, we're just so lucky to work with first responders and other social service agencies. So really quick, just a reminder of the work that we do today. I'm going to be talking about GRACE and LEAD and the way that we think about our program evaluation and the metrics and data that we collect. GRACE was launched in 2018 and LEAD in 2020. GRACE, as you probably know, is an intervention for our community members who are familiar faces to emergency systems. And we serve 80 to 100 community members at any one time. That's our current capacity. And we are always working to reduce that utilization of emergency systems and focus on the root cause of what is going on for that individual. And we're looking to improve their health and well-being and access to care that's going to work for them. And in all of our programs, we believe that people have the ability to heal and grow and find a level of stabilization that works for them. So we do that through intensive case management. In GRACE, we have 5 intensive case managers partnered with either community paramedics or law enforcement. And then we also have a nurse practitioner who works with the GRACE program as a bridge provider, a bridge prescriber. She does home visits, she does wound care, and she provides additional support to all of our housing programs in the community as well. We do keep smaller caseloads, and I'll talk more about our intervention plan and community support plan. Our programs do provide transportation to the people that we serve, and all of our support is field-based, meaning that we aren't based out of a clinic or an office. We mostly work out of cars and in the field. And then with all of our programs as well, we're thinking about the impact to the system. And so how can we act as a hub of information and connection when we're doing care coordination? So LEAD is very similar, law enforcement assisted diversion. This staffing is a little bigger. We have 5 intensive case managers and 3 outreach coordinators. So currently we serve 80 to 100 individuals at any one time. This will expand in 2023 to 120 to 140 enrolled members. LEAD is focused on creating a path out of the legal system for the familiar faces that are well known to the legal system. So that can be law enforcement as well as the courts, the jail, and all of our legal partners. I like to think about LEAD specifically as a public health approach to public safety, but I think that actually is true for all of our programs. We are also interested in identifying and addressing racial disparities in the legal system, and all of our programs are focused on client-centered care. So again, a very similar model within LEAD, which is how we operate in the field. A lot of outreach. We do have 3 outreach coordinators in LEAD, and that really speaks to the work that it takes to build relationships and build rapport with the people that are eligible for our program. Any questions? Again, I'm sorry I can't see you, so.
Laura, I don't see any hands up at this time.
Okay, great. So just our eligibility criteria and referrals. So for Grace, both Grace and LEAD have unique eligibility criteria. It's good to remember that both programs are voluntary, but we work really hard to build rapport with individuals, and I would say we're quite successful in enrolling most individuals that meet the eligibility criteria and have been referred. So for Grace, we're looking at utilization data. We look at EMS contacts, that would be across the 14 fire districts in Whatcom County. Law enforcement interactions, again, all of our law enforcement agencies, we look at utilization for our emergency department at St. Joe's, our jail, and then we also look at multi-system interactions when someone might not meet criteria of high utilization in one area, but are they hitting all of those areas? We also look at emerging utilization. So when someone maybe doesn't have that 12 months, but they have 3 months of EMS contacts and it went from 0 to 6 EMS contacts, that tells us a story. And often we want to look into that and see if that person would be a good fit for Grace. And again, we're looking at 12 months prior to when we get the referral. With LEAD, we're looking at chronic low-level law violations or police contact in Whatcom County. And we look back 24 months prior to the referral. Just something to note, an individual cannot be enrolled in Grace and LEAD at the same time. But we have had some really successful cases where we've been able to transfer someone from one program over to the other. And that's been good. And we also then do some cross-program support when that's needed. Referrals for both programs come from law enforcement, EMS, our jail and legal system partners, healthcare providers, and social service providers. So when we're building and evaluating these emerging programs, we're thinking about really two main things. What is our impact to the system? And then how are we supporting the individuals that we serve? How is our health and well-being improving? So with that system impact, we're curious about the interventions that we provide and looking at the utilization data and trying to determine if it is making an impact to the larger system. I would just say, when we look at this type of data, it's really complex and there's lots of different factors. And so it's hard to determine if our programs are, one of those factors that might change someone's utilization. And so as the program continues, we get more and more years of data, I think we're going to have a stronger case to make that actually, in fact, this is a solid intervention and here's multi-years of reduction in service and utilization. And so that's where we're going. So the goals for utilization data include law enforcement interactions. So we want to know which, of course, there is 911 dispatch that we have, and then we also have when a law enforcement officer writes a report. So our goals around that would be to look at both. So again, I'm talking about goals. In EMS interactions, that's any time that an EMS crew is interacting, is on a call, a 911 call. And again, that's across all the fire districts. And then ED visits, when do people show up at the hospital, and jail booking. So those 4 utilization points is where both programs we're looking to see what our impact is. We use the Gelada software platform for this data integration. And this again is really a work in progress. To date, we have access to jail bookings and EMS contacts through a platform interface, meaning that when our staff go into Gelada and work on their client file, they actually see accurate EMS contacts and jail bookings inside of the patient file. We don't yet have that type of interface with law enforcement, 911 dispatch, and the emergency department. And I think all of you have heard some of the outcome data from Grace and LEAD from Jeremy Morton in the last couple of months. We will continue to be working really closely with Jeremy to develop data dashboards that are built for the community. And so those infographics will be something that we're able to publish and that people are able to engage in that outcome information without really getting in the weeds of our emergency systems. So that goal of having those data dashboards is really right around the corner. And I would be happy to come back at some point next year, maybe with Jeremy and provide a deeper dive into that. What we know from the outcome data that we have is that there is a strong correlation that once someone is engaged in our programs, both GRACE and LEAD, we see a reduction in interaction with EMS and jail bookings. And that has been consistent as these programs have stabilized in 2021 and then the data that we're looking at for this year. Again, all of that analysis is still, we're at the beginning of that. And we're eager to include law enforcement and the ED in that picture. But we do have the advantage of looking back in time historically what someone's utilization was. And then after they complete the program, we're also able to see how they're doing. So one of the big takeaways from the current analysis is that if we put a reduction of cost to EMS contacts and ED visits when someone has completed the program, we see at the time of completion, they have a 90% reduction in EMS contacts and jail bookings. That trend continues when we're able to look at 12 months after finishing the program or being closed from the program, and 24 months, that's staying consistent at a reduction in cost of at 75%. So again, would love to provide more information about that if folks are interested. So that's our system work. And then the human side of it are when we think about health and well-being and what does stabilization look like, this is really the work of intensive case management, which is care coordination. And all of that work is relationship-based, relationships with those we serve and with our community of providers. And again, we do this work as a community. There's really no other way to do it. So, you know, how do we capture the achievements that our clients have been able to achieve while they're engaged in our program? So we do that through building, building an individual intervention plan. And that's created with the client that reflects their goals. And it always has a focus on moving out of crisis, either in our emergency systems or our legal systems, and towards stability. And we know that stability looks different for every person. We have an amazing group of staff that are able to do this work through motivational interviewing and assertive engagement strategies to engage and build rapport and really support folks and walk alongside folks. And again, we don't do that in a vacuum. We do that with the community. And so the next step is to build a community support plan where all of our partners know their role and we're able to provide linkages across systems that maybe traditionally haven't talked to each other or haven't been able to do the work together the way we would hope.
Laura, if I could I interject really quick? Okay, as I'm about to go off to my doctor appointment, you know, one of the things that our task force has looked at is with Dr. Alexis Harris, this data question. And so you are not boring us when you talk about data and how challenging it is, but also what you're able to know. And one of the things that just occurred to me as I was listening to you, sometimes those things can be so difficult because we need really data experts to kind of do some of the messy work of trying to control for externalities that we couldn't control for, to, you know, get clause in the systems, to be able to tease out what data is there, but it has to be cleaned up. It's often quite messy. So on my way out, and I know it's a parting shot, but maybe, and I know Stephen is still on the call with us, but if that would be something that at some point, maybe partnering with organization like the University of Washington or educational resources who, you know, if you could comment to the group and for the sake too of the recording on what your thoughts might be on partnering with an educational institution to further that goal of figuring out kind of your outcomes and your impact. I can say anecdotally, your street cred, people see the folks in your program, you know, they're cheering. But I think you're right. You need the data to back it up. So if you wouldn't mind, as you close out, think, you know, could that be something that could be useful to Grace? And then Stephen maybe commenting on work with Dr. Alexis Harris, and would that be something that might fit? And I have to leave, but thank you again for your presentation. It's always great to see you, to hear you, and thank you for joining us today.
Yeah, thanks, Mike. Yeah, I would just say that we're really at the beginning of building the data system that we need for these programs, but we can't do that without having visibility across all of the different systems. And so I know that that is a huge effort and a big dream, but being able to work with an educational institution would be wonderful. I would say that we have been launching for quite a while. You know, these programs are still quite new, and the move into the county allows us now to have the support of a data team and a communications team, and that we hope in the next year that we're going to be able to produce the type of visibility that the community really wants, and that can drive the conversation about what we want to invest in the future, where our gaps are. Do we know what we would recommend if we had the opportunity? And so I would just say that we're at that point in the health department in building those systems, and being able to partner with our universities would be a great next step. And I know we're really short on time, so I'm just gonna, the highlights of our individual intervention plans is that we're able to track the goals and know how long it took for someone to achieve those different goals. And it's everything. It's, you know, we're looking at the whole person. So it's physical health and mental health and housing and transportation and substance use and basic needs and insurance and documentation, all of it. Pro-social activities are all part of that, along with crisis planning and support. And, you know, we've served since 2018, we've served over 400 individuals in these two programs with almost 1,000 connection to services in that time. And just for folks to know too, the frequency at which intensive case managers work with people, in that time we've had over 11,000 enrollment interactions, meaning that is when our staff have been working with clients or working on their behalf in the community. So one last piece is just participant voice is the next piece that we are working on. We already have client surveys as part of our LEAD program, and we'll be implementing that in Grace in 2023. It's been a really meaningful part of, they're voluntary, but people have been very willing to participate in the surveys, and it allows us to really dig into how they think they're doing and what their satisfaction with the program is. And then there's also some qualitative questions around their goals. So I'm going to stop sharing. We are right at time. So I don't know if there's time for questions, but or comments.
Well, I do just want to make one quick comment, is that the HCA Substance Use Recovery Services Advisory Committee, known as SURSAC, is the committee that was organized to respond to the Blake decision to the legislature. One of the things that the SURSAC committee really focused on, and I was part of for almost a year, is this idea of data collection. So I know for sure that one of the recommendations to the legislature is to increase the ways by which we collect data from law enforcement, from the prosecutor's office, from correctional facilities, and so forth. So I do know there's just a rich conversation going on around data collection. So thank you.
That's really good to hear. And I think, as I mentioned multiple times, we know that Gelada allows us to build an interface that then allows us to build dashboards for our community so that we can understand what's happening. And I really do believe that we'll be able to build those interfaces soon. And it would be helpful if the state was also supportive of that.
I just want to comment on that too, Malara. And Actually, that's the work that Jeremy's been able to sort of build a bit of a foundation on locally, because he had to really kick some doors open to, number one, just get people to talk to each other, but number two, to get people to agree to share that information. So locally, I think he's made some great strides. But at the state level, there's organizations that just don't get it, or they don't understand it, particularly our hospital system. And so, yeah, as we move on, at least from my sector, I'm really pushing our state EMS committees to really push hard on the hospitals to create these sharing, because that's where the majority of the outcomes are found out, are through these hospital systems. So anyway, yeah, thanks for that. We really need to push that, and especially with Representative Rule at the earlier part of the meeting, to tie all that together at the state level too.
So we are a little bit past time, and we do have one hand raised. Jill, would it be okay if Courtney chimed in?
Yes, of course.
Oh, I hate to be the last one to keep a meeting running long. I was just going to say thanks, Melora, and just on the topic of data collection and how things are developing and growing, we just invite you to always know that you can reach out to the public defenders, and that me and Nathan are here to help, bridge with that communication and data. So thank you.
I really appreciate that, Courtney. And, the Public Defender's Office is one of the examples of just the strong partnerships that have been built in doing this type of intensive case management. And I know that's a lot of the work that you do as well. So appreciate that.
Thanks.
Well, thank you. And on behalf of both chairs of this committee, we certainly want to thank all of our presenters today. It's been a robust conversation and a lot of information shared. Our next meeting is November 15th at the normal time at 9 a.m. But you might want to note that the December 13th meeting looks like it's going to start at 1:30 versus 9 a.m. So if Jill, can you verify that?
Yes, that's correct. The December meeting is a joint meeting with the Legal and Justice Systems Committee.
Sure. So at that point, I think we can adjourn. And thank you so much.